tendon transfers are, they're really the ultimate reconstructive chess match. You're taking a hand with irreversible nerve damage
Yeah.
and just rewiring it for function using spare parts.
Yeah, it's pure biomechanical engineering right there on the operating table.
Exactly. So if you are scrubbing in tomorrow on like a late-presenting radial nerve palsy, or maybe you're staring down a devastating high-median injury, this deep dive is your blueprint. We are doing a high-yield run-through of the physics, the biomechanics, and the workhorse clinical setups for upper extremity tendon transfers.
Because you aren't just reconnecting anatomy here, you're fundamentally redesigning it. You're looking at a paralyzed limb and having to calculate vectors and excursions just to bring it back to life.
Right. But before we even think about which tendon to move, we really have to talk about where it's going and, the environment it's crossing. The absolute non-negotiable rule on day one is that the joints must be completely supple prior to transfer.
Oh, absolutely. You simply cannot force a tendon through a brick wall.
You really can't.
It is the most common reason these procedures fail. A tendon transfer doesn't generate new joint mobility, right? It only powers the mobility that already exists.
Right. So if you have, say, a 30-degree flexion contracture at the PIP joint, your new transfer is just going to pull against a rigid block.
And stretch right out. Exactly.
Yeah, and right alongside that is the concept of soft tissue equilibrium. Your surgical bed has to be entirely free of edema, inflammation, scar tissue.
Because you're essentially laying down a new gliding surface.
Right. If the bed is hostile, you're doomed.
A tendon routed through an inflamed bed will just form dense adhesions. It gets tethered, you lose your glide, and the whole transfer is rendered useless. I mean, if you're dealing with extensive scarring from a crush injury, you might actually need to bring in a fasciocutaneous flap first.
Just to resurface it.
Yeah, resurface the area,
Yeah.
provide a healthy gliding bed like weeks before you even attempt the tendon transfer.
We've all had that patient in clinic, though. The one who comes in with a severe contracture and a nerve palsy, and they get just begging you to fix the joint and move the tendon all in one surgery.
Yeah, to save time.
Exactly. It's so tempting to agree and, be the hero.
Yeah.
You have to hold your ground. Here's a common pitfall. Why is combining those two things in a single stage such a bad idea?
Well, because it creates an impossible rehab mismatch. Think about the post-op protocols. When you do a surgical contracture release, your immediate goal is prolonged, aggressive mobilization.
Right, to prevent that joint from freezing back up.
Exactly. But a tendon transfer, that needs 3 to 4 weeks of strict, absolute immobilization to let the tendon heal solidly at its new insertion site.
You literally can't do both at once. If you move it, you rupture the transfer. If you splint it, the joint contracture comes right back with a vengeance.
It's a lose-lose scenario. So you stage it. Send them to hand therapy or do your surgical release first. Get the joint supple, wait for the tissues to quiet down, and only then do you bring them back to the OR for the transfer.
Okay, so let's say the bed is optimized. The tissue is quiet, joints are supple. Now we get to the actual engineering. Picking the right motor comes down to absolute physics.
Yeah.
We're matching the donor to the recipient, and that means balancing 3 variables: excursion, strength, and tension.
Right, so excursion is just how far that muscle can pull its tendon. You need a donor that has enough linear movement to get the full desired arc of motion. The workhorse rule of thumb here is flexors give you about 70 millimeters of excursion, extensors give you 50, and wrist motors give you 30.
So if you're trying to power a flexor that needs 70 millimeters of pull, you can't just hook up a wrist motor that only pulls 30.
No, you'll run out of runway before the finger's even close.
And then you have to factor in strength. A weak donor fails, but an overly strong one is a disaster because it creates entirely new abnormal postures.
We measure this in relative units. Your brachioradialis and your flexor carpi ulnaris are the absolute powerhouses. They each have a relative strength of 2 units.
Wow, okay.
Yeah, while your extensors sit around 0.5, and then you have something like the palmaris longus, which is barely a 0.1.
So you never want to put a massive motor on a delicate system. In real life, I've seen cases where a surgeon takes the brachioradialis and plugs it directly into the extensor pollicis longus.
Oh, that's just overpowering the system.
Yeah, you give that patient a severe extension contracture, and the resting posture of their thumb becomes totally non-functional.
Which brings us to tensioning on the table. This is, without a doubt, the most technically demanding part of the operation.
Oh, for sure.
You can pick the perfect motor, but if your tension is wrong, the transfer is worthless. Your goal is to maximize the actin-myosin overlap in the muscle belly.
You want that muscle pulling at its absolute peak physiological efficiency.
Hmm.
And the way you actually do this is by restoring the preoperative resting tension. The trick I always teach the residents is to mark the muscle belly with sutures at regular intervals before you divide its insertion.
That's a great tip. You establish your baseline.
Right. Then, when you route it to the new target, you set the tension to restore that exact distance between your suture marks. Because if you set a tendon transfer too loose, it's game over.
It will never magically tighten up postoperatively. It's just going to stretch out even more during rehab.
It's exactly like a failed levator advancement for tosses up in the face. If you don't establish the correct resting tension while the patient is on the table, you just don't get the dynamic lift you need.
Mm-hmm.
A loose tendon is a dead tendon.
And we really can't talk tension without talking biomechanics, specifically the moment arm. The moment arm is the perpendicular distance between the joint's axis of rotation and the tendon crossing it.
I always think of the moment arm like pushing a heavy door open.
Oh, yeah, that's a good analogy.
Yeah, so if you push right near the hinge, meaning you have a very small moment arm, you don't have to move your hand very far, but you need an immense amount of physical force to swing the door.
Right.
But if you move your hand way out by the handle, a large moment arm, it takes almost no force at all, but your hand has to travel a much greater distance to get the door open.
That's the perfect way to visualize it. Passing a tendon far from the joint axis gives you massive torque, but it costs you arc of motion.
Yeah.
You're going to need significantly more excursion from your muscle just to get the same amount of joint rotation.
And conversely, passing close to the joint gives you a fantastic arc of motion, but much weaker torque.
Exactly. You have to constantly balance those two needs when you're choosing exactly where to anchor your insertion.
Let me throw a real-world scenario at you regarding excursion mismatches. So we established that the flexor carpi radialis, a wrist motor, has about 30 millimeters of excursion.
Okay.
But we frequently use it to power the extensor digitorum communis, which needs 50 millimeters to fully extend the fingers. How are we overcoming that 20 millimeter physiological deficit?
Oh, we use the tenodesis effect. It's basically a built-in biomechanical cheat code.
I love that.
The patient learns to simultaneously flex their wrist while extending their fingers. When they drop that wrist into flexion, it physically increases the distance between the origin of the FCR and its new insertion on the EDC.
So that extra distance adds the exact effective excursion you need to get the fingers fully straight.
Exactly. And the brain remaps the synergism remarkably fast.
Radial nerve palsies really make you feel like a hero because getting extension back relies on that exact principle. You're dealing with a classic drop wrist, high radial nerve palsy.
Right, the patient has lost wrist extension, finger MCP extension, thumb extension, and radial abduction.
And here's a detail that gets missed. Their grip strength plummets, not because the flexors are dead, but because they can't stabilize the wrist in extension to give the flexors something to pull against.
To fix that wrist, the universal workhorse is the pronator teres transferred to the extensor carpi radialis brevis, the PT to ECRB.
Here is a crucial point for anyone doing this. You specifically want the ECRB, not the ECRL. It seems counterintuitive because the longus is bigger, but if you transfer to the longus, you're going to drive the wrist into severe radial deviation every single time they try to extend it.
Yeah, the ECRB sits more centrally, so it gives you a straight, balanced dorsal pull. And while the classic surgical move is a standard end-to-end pulver-taft weave, we really have to talk about the internal splint.
Oh, right.
If there's any chance that the radial nerve might spontaneously recover, say it's a traction injury or a primary nerve repair you're waiting to see wake up, you perform the PT to ECRB as an end-to-side transfer.
You know, I remember scrubbing in as a junior resident and being completely confused why we were intentionally leaving the paralyzed ECRB attached. It felt messy. You're taking your healthy donor and suturing it into the side of a dead tendon.
Right.
Doesn't introducing that angle alter the straight line of pull and compromise the mechanical efficiency of the weave?
It does alter the mechanics slightly, yes. You're sacrificing a small degree of immediate mechanical efficiency. But the trade-off is your insurance policy.
How so?
By weaving end to side, you're leaving the native ECRB muscle attached to its origin. If that radial nerve actually regenerates 6 months down the line, the native muscle can start firing again and contribute to wrist extension alongside your transfer.
So you're giving them immediate function so they can use their hand without burning the bridge of spontaneous nerve recovery.
Exactly. The end-to-side weave becomes a total no-brainer when you look at it that way. Now for the fingers. To get MCP extension back, you generally have 3 options: FCR, FCU, or FDS to the EDC.
And for decades, taking the flexor carpi ulnaris was the gold standard. But modern practice has really shifted away from it.
Because taking the FCU ruins the dart throwing motion.
Right.
That specific arc from radiocarpal extension to ulnocarpal flexion is functionally critical. It's how we hammer a nail, how we cast a fishing rod, how we throw a ball. If you take the FCU, you kill that motion.
Plus, in a radial palsy, they've already lost their extensor carpi ulnaris. If you take the FCU too, you've completely removed every single ulnar-sided wrist motor. The wrist just becomes horribly destabilized.
So the flexor carpi radialis becomes the highly preferred donor. And for the thumb, you're typically looking at the palmaris longus or a superficialis tendon transferred to a rerouted extensor pollicis longus.
Rerouting the EPL out of the third dorsal compartment and shifting it radially is such a slick move. It changes the vector so that a single pull restores both thumb extension and radial abduction simultaneously.
It's an elegant solution, but let's step up the complexity ladder. Moving from the radial nerve to the median nerve takes us from straightforward extension to the most intricate, uniquely human movement we have, which is thumb opposition.
Yeah, high versus low median nerve injuries completely dictate what spare parts you actually have left in the toolbox. A low palsy, like a bad carpal tunnel or a distal laceration, knocks out opposition. Though sometimes you get lucky with a reach canoe connection from the ulnar nerve that preserves it.
Yeah, that's always nice.
But a high median palsy is a humbling disaster. You lose the FDS, you lose the flexor pollicis longus, and you lose the index FDP.
Restoring opposition is incredibly difficult because you aren't just creating a simple hinge joint. True opposition requires a combined 3D vector.
Right, you need palmar abduction to pull the thumb away from the hand, you need pronation to rotate the thumbnail so it faces the fingers, and you need flexion to bring it across the palm.
You're trying to recreate all three of those simultaneous movements with a single line of pull.
So let's break down the opponent's plasty options. The superficialis transfer, usually taking the ring finger FDS, is highly reliable. But the key to making it work is that you have to create a pulley down at the pisiform. You can use a window in Guyon's canal or a slip of the FCU.
But obviously you can't use an FDS transfer in a high median palsy because those muscles are denervated.
And here's the trap. If the patient had a severe volar wrist laceration that caused a low median palsy, chances are the glass or the knife sliced right through the FDS tendons too.
Oh, yeah. If the FDS is gone, the extensor indicis proprius, the EIP, becomes your best friend.
I love the EIP transfer. The donor deficit is minimal since the index finger still has the EDC for extension. And biomechanically, it naturally pulls from the ulnar side of the wrist as it comes around the border of the forearm, so you don't even need to surgically construct a pisiform pulley.
It's a fantastic backup. You also have the Kamitz transfer using the palmaris longus. We use that a lot for severe end-stage carpal tunnel atrophy because you can harvest the palmaris right through your extended carpal tunnel incision.
But it has a major limitation, right?
Yeah.
It gives you excellent palmar abduction, but it lacks the flexion vector to truly bring the thumb across the palm.
Exactly. And then there's the Huber transfer, where you literally turn the abductor digitory minimi muscle over like the page of a book. But we reserve that mostly for congenital thumb hypoplasia, where the goal is as much about restoring the falmo bulk for appearance as it is about function.
Let's go back to that superficialis transfer for a second, because the pulley mechanics are fascinating. How exactly does routing a tendon all the way over to the ulnar side of the wrist, wrapping it around the pisiform, actually recreate the 3D magic of thumb opposition?
It all comes down to the origin point of your vector. Think about the geometry. Most opponents' plasties insert on the abductor pollicis brevis tendon.
Okay.
If your line of pull originates proximal and radial to the pisiform, you get pure palmar abduction. The thumb lifts straight up away from the palm, but it doesn't rotate.
And if your line of pull is too distal, you get pure flexion sweeping across the palm without the lift.
But when you anchor that pulley exactly at the level of the pisiform, you hit the sweet spot. That specific ulnar-sided vector pulls the thumb up into palmar abduction, flexes it across the hand, and the tension physically forces the first metacarpal to pronate.
So it perfectly balances all three planes of motion.
Yes. If your pulley is off by even a centimeter, the mechanics fail.
That's the kind of anatomical detail that makes this field so incredible. Okay, let's finish with the most biomechanically complex deficit we face, the ulnar nerve palsy. The loss of the intrinsic muscles completely derails the entire balance of the hand.
Because you've lost the lumbricals and the intraossei, you've lost your primary MCP flexors. That means your extrinsic muscles are running completely unopposed.
The powerful EDC continuously drives the MCP joints into hyperextension, while the FDP and FDS slam the IP joints into rigid flexion.
That's your classic claw hand.
I want to highlight a massive pitfall here for any resident managing these patients post-op. It's called the paradox of the claw. In a high ulnar nerve palsy, say, a transection up at the elbow, the clawing in the hand is actually less severe than in a low palsy at the wrist.
It sounds backward, but it's true.
Why? Because a high injury knocks out the ulnar innervated half of the FDP. The flexors to the ring and small fingers are dead. You lose the extrinsic flexor pull that drives those IP joints into the severe claw posture.
And the trap snaps shut during the recovery phase. Let's say you do a primary repair of that high ulnar nerve. As the nerve regenerates down the forearm, it reaches the FDP muscle bellies first.
Suddenly, those forearm flexors are re-innervated and firing again.
But the nerve front hasn't reached the hand yet, so the intrinsics are still dead.
So a resident sees this post-op patient in clinic at 4 months. The clawing looks dramatically worse than it did on day 1. They completely panic. They think the repair blew out or scar tissue choked the nerve.
Yeah, they freak out.
But worsening clawing in a recovering high ulnar palsy actually means your nerve repair is working perfectly. The regenerating nerve front has simply woken up the forearm flexors before the hand intrinsics.
It's a phenomenal clinical sign, cleverly disguised as a complication. You have to counsel your patients about it beforehand so they don't panic either. Now, when the time comes to actually correct the claw surgically, your entire decision tree relies on the Bouvier test.
You do this right in the exam room. You passively correct the MCP hyperextension by taking your finger and pushing their knuckle down into flexion.
And if the patient can then actively extend their IP joints using their own extrinsic extensors, the Bouvier test is positive. The central slip is competent. We call that simple clawing.
Right. And if you have simple clawing, you don't necessarily need a complex dynamic muscle transfer. You can get away with static blocks. A volar plate capsulodesis is a great option.
Yeah, you surgically advance the volar plate proximally to permanently block that MCP joint from popping up into hyperextension. It acts as an internal check rein.
But if you push that knuckle down and the IP joint stays stuck in flexion, that's a negative Bouvier. That's complex clawing.
The central slip has stretched out. Static blocks won't work here. You have to bring in dynamic transfers to actively restore intrinsic function.
For dynamic transfers, you're looking at operations like the Zancoli lasso. You take an FDS tendon, split it, and route it through the lumbrical canals to insert on the A1 pulley or the lateral bands.
Or you can use elongated wrist motors. You take the ECRL, attach a massive split tendon graft, like a four-tailed plantaris graft, and route those slips through the intermetacarpal spaces to actively pull the proximal phalanges into flexion.
The overarching goal of all these dynamic transfers is to restore active MCP flexion. That reverses the clawing, sure, but more importantly, it fixes the roll-in grasp.
The roll-in grasp is so frustrating for patients.
Without intrinsics, a patient's fingers roll into the palm, starting from the fingertips first. It's like rolling up a carpet. When they try to grab a cup, their fingertips just push the object right out of their hand.
Restoring that active MCP flexion allows them to fold the hand at the base first, cupping the object normally. And we can't forget about the thumb. In an ulnar palsy, you have to restore key pinch. The adductor pollicis is ulnar innervated, and losing it just devastates pinch strength.
To restore it, you're usually taking an elongated ECRB or brachioradialis. You route the transfer from the dorsal forearm, dive it volarly through the second or third intermetacarpal space, run it straight across the deep palm, and anchor it directly onto the adductor insertion of the thumb.
It gives them the crushing force they need to hold a key or turn a doorknob. But here's the reality check for everyone listening. You can execute all of these transfers flawlessly. The tension can be perfect, the routing can be anatomical, but the operation itself is only half the battle.
Oh, the ultimate result hinges entirely on the rehabilitation. You close the skin, but you aren't done. The standard protocol requires strict, unforgiving immobilization for 4 weeks.
At 2 weeks, you might swap the bulky surgical splint for a rigid cast, but the patient does not move those joints.
And at 4 weeks, you finally transition to a custom removable splint and start very gentle, synergistic active training. You're trying to literally remap the motor cortex of the brain.
They're teaching them to fire a wrist flexor when what they actually want to do is extend their fingers.
And you hold off on passive stretching until 6 weeks. If you let a therapist aggressively stretch them too early, you're going to stretch out the repair, ruin that perfect tension you set on the table, and the transfer fails.
Strengthening doesn't even enter the conversation until 8 weeks post-op. Getting back to full, unrestricted, heavy activity is a 3-month destination minimum.
It takes immense patience from both the surgeon and the patient. But, when you really step back and look at the anatomy we've dug into today, you have to appreciate the sheer evolutionary design of the forearm.
It's amazing.
The human hand is built with this massive, almost redundant surplus of power. You have 3 wrist extensors. You have 2 wrist flexors. You have 2 entirely separate flexor systems for every single finger.
It's an incredibly forgiving system.
It's as if the anatomy was perfectly designed with built-in spare parts, just waiting for a surgeon to creatively rewire them when disaster strikes. Think about that the next time you're dissecting out an FCR. What other system in the human body gives you that much raw material to fundamentally rewrite its own biomechanics? That's what makes this surgery an absolute privilege to perform.